Hello, my name is Brittney Murray. I'm a clinical cardiovascular genetic counselor at Johns Hopkins Hospital in Baltimore, Maryland, and today I'm going to be discussing inherited cardiomyopathies. A little bit about me. I'm a clinical genetic counselor in cardiovascular genetics at Johns Hopkins Hospital in the Center for Inherited Heart Disease, and also the clinical genetic counselor in the Johns Hopkins ARVCI program, which is a specialized clinical and research center dedicated to this rare cardiomyopathy. I'm active both within the Hopkins and Maryland genetic counseling programs, both as a supervisor, but also developing and instructing their cardiovascular genetics curriculum. And I'm the co-chair of the National Society of Genetic Counselors Cardiovascular Genetics section. So I'm involved in cardiovascular genetics both at a regional and national level and passionate about this topic. Increasingly, there are more and more genes that are implicated in providing risk for inherited cardiomyopathies. If we would have showed this slide just a few short years ago, large cardiovascular cardiomyopathy panels included maybe 20-25 genes. Today, this is an ever-expanding large group of genes, and there is ever-expanding overlap between all of these conditions that we used to think were very separate boxes, providing increasing complexity within the management of patients with inherited cardiomyopathy. Today I'm hoping to go through with you just a few of these inherited cardiomyopathies and go through the genetic component to them and some management implications, going through the most common inherited cardiomyopathies, including hypertrophic cardiomyopathy, dilated cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, and left ventricular non-compaction cardiomyopathy. We'll start out with case examples to really provide a foundation for many of these topics. The first example is a 45-year-old woman referred by her cardiologist. Her 20-year-old son had passed away while driving his car. The autopsy report showed cardiomegaly. His heart rate was 600 grams. Both the right and left ventricles were hypertrophied. The walls measured 0.6 centimeters and 2.1 centimeters respectively. Microscopic evaluation showed myocyte disarray, and the cause of death on the autopsy was listed as hypertrophic cardiomyopathy. In talking through the history of your patient, we find that she had a history of hypertension diagnosed at 25. She also had been diagnosed with multiple sclerosis at 36 and diabetes at 44. Importantly, she had had multiple syncopal episodes since her late 30s. Her ECG was also abnormal, and her QT interval was at 517 milliseconds. Her ECG findings suggested that there was hypertrophy of the left ventricle, and this was thought to be consistent with a diagnosis of HCM in her as well. The entire family history was reviewed, and there was no other significant family history. Her parents died in their 80s of unrelated causes. Genetic testing was sent in this patient after her diagnosis of suspected HCM, and genetic testing identified a myosin heavy chain mutation, arginine 6-3 histine. This mutation is strongly expected to cause a risk for cardiomyopathy. It has been reported in more than 20 unrelated HCM probands, and in those families has been shown to segregate with disease. This is consistent with a diagnosis of genetic hypertrophic cardiomyopathy within this family. Hypertrophic cardiomyopathy is a common inherited cardiomyopathy with an incidence in about 1 in every 500 individuals, although more recent reports suggest that it may be even as common as 1 in every 200. The average onset is extremely variable, although most are from the teenage to mid young adulthood age range, about 35 years old. This illustration is an illustration of a sarcomere that I like because it goes through all the different components of a sarcomere within the heart muscle, and really mutations in any of these proteins can lead to a diagnosis and presentation of hypertrophic cardiomyopathy. We know that hypertrophic cardiomyopathy is caused by a genetic cause in about 60 to 70% of cases, so this is a large portion of HCM patients. In 2014, The European Heart Journal and the European Society of Cardiology published guidelines on the diagnosis and management of HCM patients. Diagnosing HCM can be made at times off of the 12-lead ECG. About 6% of patients have a normal ECG, but often will have LVH or ST and T wave abnormalities. On telemetry monitoring, even asymptomatic patients can be found to have non-sustained VT at rates between 120 and 200 beats per minute in about 25% of adults with HCM. Paroxysmal supraventricular arrhythmias also occur on telemetry in about 38% of patients. When diagnosing a patient with HCM, ECG and Holter monitor are recommended at diagnosis along with imaging, and MRI is often recommended if HCM is suspected at initial evaluation. In that European Society of Cardiology paper, they go through this schematic of the diagnostic flow of diagnosing a patient with HCM. Clinical evaluation can include obtaining symptoms and a pedigree from the family, as well as the ECG and other evaluations discussed before. And then genetic testing is implicated in these guidelines as an important piece of the diagnostic flow. Importantly, also in this evaluation, genetic counseling is recommended in these guidelines as a class 1 indication when you cannot explain HCM solely by a non-genetic cause. This is recommended whether or not genetic testing will be used to screen family members. It is recommended for the patient you're taking care of. And a class 2A recommendation is that this genetic counseling is performed by a trained individual, such as a trained certified genetic counselor working within a multidisciplinary team. And this is because HCM genetics can be very complex. 40 to 60% of genetic HCM is caused by sarcomere mutations. So mutations in myosin heavy chain and myosin binding protein 3 make up the large portion of genetic hypertrophic cardiomyopathy. However, 5 to 10% of genetic hypertrophic cardiomyopathy can be due to a whole host of syndromic and other causes, such as neuromuscular disease, metabolic disease, and malformation syndromes, especially Noonan's syndrome, cardiac amyloidosis, and other known genetic components to disease. Finding an underlying genetic risk factor and also of obtaining the complete family history of a patient with HCM can be helpful in obtaining their risk of sudden cardiac death. Within these European Society of Cardiology guidelines, they do indicate that a family history of sudden cardiac death at a young age is considered clinically significant and indicates that the proband or the patient sitting in front of you is at higher risk of sudden death than would be expected just based on their clinical evaluation alone. So genetic testing is recommended for HCM patients. Next generation sequencing has a detection rate of about 60 to 70%. This meaning that your patient sitting in front of you that you suspect a genetic cause for their HCM, you'll be able to identify their underlying genetic risk factor in 60 to 70% of cases. 2 or more mutations contributing to HCM can occur in about 5% of individuals tested for HCM. This is often in patients when they have a younger age of onset in more clinically severe HCM. This has implications not only for the patient who is severely affected sitting in front of you, but important implications for cascade screening within the family. And this is really where we're hoping that genetic testing in HCM is going to be going in the future. There are increasing clinical trials, such as the VANISH trial, showing that there are increasing clinical trials with HCM patients with known sarcomere mutations, showing that diltiazem treatment for preclinical HCM in sarcomere mutation carriers may lower the impact of disease in these patients. These clinical trials are, of course, ongoing, but this is really the hope of genetic medicine within not only inherited cardiovascular disease, but all of genetics. Moving on, here is another case example. This is a case example that was reviewed in the intro to cardiovascular disease if you watched that section of this webinar series. However, as review, this is a 38-year-old woman presenting with increasing exercise intolerance. This is the woman right here. At first, treating only this woman, she was treated for exercise-induced asthma, but that did not help her symptoms. She was recommended to have a cardiology evaluation, and echo revealed she had a depressed ejection fraction at 45%. Her ECG also showed first-degree AV block. She was told that this was possibly a virus or a viral cardiomyopathy and was told to limit her activity and that the symptoms may resolve over time. However, her primary care physician noted her family history and asked for a cardiovascular genetics workup. When she was seen in our clinic, this is when we took this pedigree here on the left, showing that she has extensive family members who have had heart transplants or died of heart failure or died of sudden cardiac death, including a first cousin who had a heart transplant and died shortly afterwards at age 25. Genetic testing was sent for inherited cardiomyopathies, which showed a splice site mutation in the lamin gene. This splice site mutation was novel, but it was predicted to destroy a splice site and lead to abnormal gene product. Now we know that because this patient carries a lamin mutation, we know that she is at higher than normal increased risk of sudden death than based on her ejection fraction alone. So we now know that this patient would be recommended to have a prophylactic ICD placed. This also is important management for her future family members who are still living about their arrhythmic and sudden death risk. Dilated cardiomyopathy is a cardiomyopathy characterized by LV enlargement and systolic dysfunction. Normally, as you know, the LV ejection fraction is below 50%. Idiopathic DCM in the United States has a prevalence estimated about 1 in every 2,000. It has a very variable age of onset, although the average age is around 40. It can make things difficult because this inherited cardiomyopathy can have reduced penetrance. In some cases, only 40% of mutation carriers may develop disease. However, in other cases, such as specific genetic risk factors such as lamin, penetrance can range up to towards 90% of those carrying a risk factor developing disease. There can be many acquired causes of non-ischemic cardiomyopathy or idiopathic DCM. Obviously, ischemic injury is a very common cause of DCM. You can also have valvular and congenital heart disease contributing to DCM. Toxins or thyroid disease can result in DCM. It often can be due to an underlying inflammatory condition, such as myocarditis or viral cardiomyopathy. Long-standing hypertension can contribute to DCM, previous radiation, or iron overload such as hemochromatosis. However, we know that genetics contribute a larger portion to a diagnosis of DCM than previously thought. Ray Hirschberger and colleagues have studied many cases of what was thought to be idiopathic DCM or idiopathic non-ischemic cardiomyopathy, and where they excluded many acquired causes. It is unclear, however, what percent of isolated DCM is caused by a single gene. This study really has suggested that a viral cause for DCM should only be suspected after a thorough genetic analysis. In many of his studies, lamin mutations have been found in up to 4% of apparently completely isolated DCM, and in an additional 11% of 300 apparently isolated DCM cases with no family history, known pathogenic mutations contributing to cardiomyopathy were identified. Familial DCM is diagnosed, such as the family that I discussed a few slides ago, when you have 2 or more closely related family members meeting diagnostic criteria for dilated cardiomyopathy. You can have isolated familial dilated cardiomyopathy or dilated cardiomyopathy with conduction defects. This is very commonly associated with mutations in lamin, such as was discussed before. You can also have familial DCM with arrhythmias, or what is largely starting to be overlap associated with arrhythmogenic cardiomyopathy. This can be seen along with mutations in Desmond, RBM20, the desmosomes, and other known specific causes of an arrhythmic and cardiomyopathy phenotype. In patients with dilated cardiomyopathy, it's been estimated that 20 to 50% of them have a family history of heart disease. Many of these cases of inherited dilated cardiomyopathy are inherited in what's called an autosomal dominant manner, meaning that you only have to carry one risk allele to have risk to develop disease. This is 80 to 90% of inherited dilated cardiomyopathy. However, you should be aware that there are other causes of inherited DCM, such as X-linked, which is evident in Duchenne muscular dystrophy and Barth syndrome. It can be autosomal recessive inherited, such as some of the syndromic causes of DCM, or it can be due to underlying mitochondrial disease, which is maternal inheritance. This slide really illustrates the increasing complexity of the underpinning genetics contributing to dilated cardiomyopathy. There is a wide range of overlap between DCM and hypertrophic cardiomyopathy noted genes. However, also in some cases, there's overlap between the genes contributing to congenital heart disease, as we've discussed neuromuscular disorders and other syndromic disorders. SCN5A is a continual tricky gene which largely contributes to channelopathies, but is known in 2 to 3% of cases to also contribute to a heart failure type picture along with a very arrhythmic course. And then the genes contributing to ARVCI can present in a more dilated cardiomyopathy phenotype, which we'll talk about here in a little bit. Moving on to ARVC, this is another case example. This was a 26-year-old young woman who presented to her primary care physician with what was diagnosed as anxiety. She felt frequent palpitations. She was told she had anxiety, was given a prescription for Lexapro. A few years later, unfortunately, she had a sudden cardiac arrest on the tennis court. Her ECG showed left bundle branch block inferior axis VT, and her resting ECG showed T-wave inversions in the right precordial leads. Her RV was mildly dilated, and it was suspected that she might have athlete's heart. Fortunately, after thorough evaluation within our program, she was diagnosed with arrhythmogenic right ventricular cardiomyopathy, and genetic testing was sent. Genetic testing identified a very classic plakophilin 2 mutation. This is a very common splice site mutation. It's been reported and segregated in multiple ARVC families, both in the literature and within our program. In her family, her completely asymptomatic father was also found to be a carrier. His evaluation, however, was shown to be completely normal. This patient received a new ICD, and importantly, she was counseled regarding exercise restrictions in desmosomal mutation carriers and in ARVC patients, and that she should avoid strenuous exercise, as should her father. So ARVD, or ARVC, arrhythmogenic right ventricular cardiomyopathy, is really the more appropriate term, although ARVD was a very classically used term. It's an inherited disorder characterized by fibrofatty replacement of the right ventricular muscle, which predisposes patients to a high risk of ventricular arrhythmias and usually very slowly progressive ventricular dysfunction. It has a wide range of estimates of prevalence from 1 in 1,200 to 1 in 500. There is a known founder effect in Italy, Greece, and also Newfoundland, and the average age of diagnosis is about 31 years old. So as I said, this disease is characterized by fatty infiltration of the ventricle. The heart cells separate and deteriorate because they have a genetic mutation in the desmosomes, or the connections between these heart cells. So under the mechanical stress of exercise, these connections over time break down and are replaced with fat and scar, which disrupt electrical signaling and can cause arrhythmias. This infiltration typically begins in the right ventricle, but can also be present in the left ventricle as well. This diagnosis is based on a set of clinical diagnostic criteria detailed in the Marcus et al. Paper published in 2010, was the new diagnostic criteria. Importantly, this diagnosis is not made on MRI alone. We see thousands of misdiagnoses based on MRI diagnosis alone. It is a full clinical criteria. Therefore, you should have abnormalities present both on ECG, MRI, arrhythmic, and genetic criteria, or some combination of, to suspect a true diagnosis of ARVD. ARVC is typically autosomally dominantly inherited, as we've discussed before. There are 8 genes that are most classically involved, largely including the desmosomes, which we've talked about before. Lamin presents in more of an arrhythmic overlap phenotype, such as we suggested, DCM with a lot of arrhythmias. Ryanodine receptor is more of a phenocopy, and that ryanodine receptor, discussed in the channelopathy section of this webinar series, results in a lot of arrhythmias. And if you happen to have a slightly enlarged heart, this can result in you meeting diagnostic criteria for ARVC. However, we do not think that RYR2 results in true ARVC. TGF-beta mutations are very rare and very controversial, whether this gene really contributes to risk for ARVC much at all. And TMEM43 mutations are a few single mutations which have been shown in this gene to have a founder effect in Newfoundland, which results in a highly penetrant, severe version of ARVC. Many of these genes are part of the desmosomal complex responsible for keeping the myocytes aligned, as we discussed previously. It's a highly variable clinical course, and these patients can have a broad range of symptoms. There is a decreased penetrance in ARVC, as with many of these conditions. However, only 30 to 50% of mutation carriers may develop evidence of disease. There is increasing evidence, however, that there is a strong environmental modifier in penetrance, and that vigorous exercise progresses disease and increases penetrance. Reducing exercise in ARVC mutation carriers is key in reducing ventricular tachycardia frequency and avoiding heart failure. Mutation carriers in ARVC are at higher risk of progression of disease at lower levels of exercise than gene-negative individuals, meaning if your ARVC patient does carry a mutation, they should really limit their exercise, whereas if your ARVC patient who meets diagnostic criteria does not have an identifiable desmosomal mutation, they may be able to exercise at higher levels before they show disease than your typical desmosomal mutation carrier. Recent studies have suggested restricting exercise in asymptomatic mutation carriers as well, which may reduce penetrance or help these individuals avoid developing ARVC at all. However, this continues to be a controversial topic. In the very recently released 2015 revised Bethesda criteria for recommendations for exercise in those with inherited cardiovascular disease, ARVC patients are recommended to the lowest level 1A activities, including bowling, cricket, golf, rivalry, and yoga. As I've said, increasingly there's overlap recognized between arrhythmogenic DCM and ARVC. There's a push within the field to merge these two into a large arrhythmogenic cardiomyopathy phenotype. When you're contemplating genetic testing in your ARVC patient, this is where large cardiomyopathy panels, such as the one offered in the right, may be beneficial to provide the highest detection rate for an ARVC patient. Moving on to non-compaction cardiomyopathy, or left ventricular non-compaction cardiomyopathy. Non-compaction cardiomyopathy is a very complex diagnosis. It's most basically described in that the embryonic development of the heart, the myocardium, or the muscle of the heart, starts off as a spongy layer. Then, between weeks 5 and 8, this material should compact. If the myocardium does not compact as it should, this results in non-compaction and can result in a non-compaction cardiomyopathy phenotype. Research has shown, however, that there is very poor agreement among all the proposed diagnostic criteria, and I've listed a few of the citations here. There has been a high number of apparently healthy individuals found to have prominent LV trabeculations, and these individuals, who are apparently healthy, do indeed fulfill proposed LVNC diagnostic criteria. LVNC is usually isolated, but can be seen in familial clusterings in about 45% of cases. penetrance can range widely based on the underlying genetic basis, from 50% up to 100%. An important concern in distinguishing non-compaction cardiomyopathy versus just dilated cardiomyopathy is that non-compaction cardiomyopathy generally carries a higher arrhythmic risk. Non-compaction cardiomyopathy has been identified to have underlying genetic causes of the following genes associated with different support and muscle genes. Non-compaction cardiomyopathy has been shown to be associated with the underlying component of both the muscles and the support of muscles and the regulation proteins of either. This is a brief list of some of the genes that have been associated with non-compaction cardiomyopathy. Currently, however, genetic testing has a very low detection rate in non-compaction cardiomyopathy, possibly due to the complexity in the diagnostic criteria. However, in a patient with non-compaction cardiomyopathy, you're only in current genetic testing panels going to identify an underlying root genetic cause in about 30%. These large panels may increase your detection rate when you combined an LVNC and DCM phenotypes together. Management in LVNC can be very tricky. The prevalence may differ between adults and children. In children, you're mainly worried about WPW syndrome, AV block, VT, and bradycardia. In adults, however, the most frequent arrhythmias are VT, atrial fibrillation, QT prolongation, and AV block. There have been shown to be more ventricular arrhythmias in LVNC when you have more non-compaction and more segments on MRI, and also with low ejection fraction. However, there have been other studies that show that if you are correctly diagnosed by current diagnostic criteria, there are no significantly different arrhythmic risks between LVNC and idiopathic DCM. Therefore, it continues to be complex how to manage the arrhythmic risk in patients with LVNC. Another concern in patients with LVNC is that patients with hypertrabeculation are at increased risk for stroke, and atrial fibrillation further increases that risk. So it's important to manage anticoagulation in patients with high level of trabeculation in LVNC. In conclusion, there are some key principles that are in all of cardiovascular genetics, but especially evident in the inherited cardiomyopathies. All of these inherited cardiomyopathies exhibit reduced penetrance, meaning only a certain percentage of those with an inherited risk factor may show disease. They also have a great variety of expressivity, meaning many family members with the same underlying root genetic cause may show many different forms of disease, some very mild, some very severe, meaning that individuals in the family with the same underlying genetic cause may express a wide variety of phenotypes, meaning some with the same root genetic cause have mild disease and some have very severe disease. And it's not necessarily predictable of the age that they may develop disease just based on family history alone. There is also genetic and phenotypic heterogeneity, meaning the same mutation may result in a wide variety of diseases. Just like MYH7 mutations have been seen with both dilated cardiomyopathy and hypertrophic cardiomyopathy, and also that there are many different underlying genetic causes that may cause a very similar clinical picture, such as there are 8 very common genes and mutations that can result in a very similar depiction of ARVCI. And many of these cardiomyopathies were moving towards what's called a genotype-phenotype correlation, meaning we're able to predict clinical picture based on your underlying genetic cause, such as in ARVC, patients with a desmoplakin mutation may show more left ventricular dysfunction than patients with a plakophilin 2 mutation. Or in dilated cardiomyopathy, patients with a Lamin mutation are at a higher arrhythmic risk than patients with, for example, a Titin mutation. This will be continued to be explored as cardiovascular genetics expands. I hope that this has been a helpful summary of the inherited cardiomyopathies. It's been a brief overview of each type, and there are many more details that I couldn't cover today, but hopefully you've been able to understand how the underlying genetic component to each of these cardiomyopathies can be a critical piece of the patient and family's management. Thank you.